So good morning. We'll start our session on retinopathy of prematurity, and we have few speakers who are very passionate about ROP work and has come here to share their experiences. So our first speaker is Dr. Divya Alex, a very busy vitreoretinal surgeon working in Ahalya group of hospitals. So she'll be talking to us on pathogenesis and classification of ROP.
Good morning, everyone. I thank Lekha ma'am and KSOS Scientific Committee for giving me this opportunity. So the born too soon babies, why is this subset of population so significant? Preterm birth is the leading cause of neonatal mortality, and from ophthalmic point of view, unfortunately, retinopathy of prematurity is the leading cause of preventable blindness in infants. And our country leads the top with 3.5 million preterm births, and according to UNICEF, this accounted for almost 26% of the neonatal death in the world. So this resulted in strong political commitment, and India government came up with a new plan, that is the India Newborn Action Plan, which was launched in September 2014, and it aimed to end preventable newborn death and stillbirths by 2030. So they came up with lot of NICUs, newborn stabilization unit, about 32 lakh newborns were treated since 2014. But the thing is that the quality of care needs good attention. No doubt that all of the NICUs are doing a good job, but this led to the increased survival rate of premature babies who are at risk to develop blindness due to retinopathy of prematurity. And owing to a wide variation in the neonatal care, it is even found that more mature and heavier babies develop retinopathy of prematurity. Almost about 30% of the preterm babies in an NICU can be affected with ROP, and almost 10% can go completely blind if they don't reach an eye specialist within 30 days of birth. So before coming to the pathogenesis, we have to know what is normal retinal development. So in utero, there is a perfect environment for vasculogenesis. Vasculogenesis means the de novo formation of primitive vascular network. So in utero, there is always a physiological hypoxia because the metabolic demand always exceeds the oxygen supply. So this physiological hypoxia induces certain factors such as hypoxic induced growth factor, IGF-1, VEGF, and this further leads to the process of angiogenesis. Angiogenesis is the growth of new capillaries from the pre-existing blood vessels. This is the normal retinal development. And the vasculature reaches the nasal aura by about 32 weeks and the temporal aura by about 40 weeks. So what happens in too soon born babies? No longer the ambient environment exists, even the atmospheric oxygen is a bit high for them. Then imagine when a preterm baby will be having respiratory distress, you start pumping oxygen. So instead of hypoxia, there will be hyperoxia. Initial response to the hyperoxia will be severe vasoconstriction. That is, retina sends a false signal that we don't need oxygen anymore. So there will be abrupt stoppage of the retinal vasculature at a point. This is the phase 1. So along this period, the baby starts stabilizes and you pull off ventilation, you give blended oxygen, blended air or the room air, and lot of oxygen fluctuation will be happening at this period. So this stress will lead to oxygen reactive species releasing secondary products such as VEGF, HIF. But at this time, all will come back with vengeance. That is almost 136 times more than what was required in utero. So this stage will cause to vasoproliferation, and this is phase 2. So in simple terms, in utero there is a physiological hypoxia, there will be normal vasculature, and thus ROP phase 1 will be hyperoxia, that leading to downregulation of VEGF, and there will be pathological hypoxia leading to vasoproliferation in phase 2. So always remember, ROP is a time-bound disease. This won't be present at birth. This will take 2 to 3 weeks to develop. So there came the famous phrase, keep an eye out for babies at 30 days. So how exactly the disease progress? So in the retina, there will be vascular retina and an avascular retina. So when a demarcation line happens between the two, this is called as a stage 1, and the line gets a little bit of height, width and a base, that is the ridge, stage 2, and extravascular proliferation occurs, that is the stage 3, and partial retinal detachment occurs stage 4, and a complete retinal detachment at stage 5. So let's see some images. So from the optic disc, you start tracing the retinal vessel, and you can see there is abrupt ending of the retinal vasculature at the point, and after that you can see only translucent zone. So this is the avascular retina, or what we call as incomplete vascularization. So this is the stage 1 where you see a demarcation line between the vascular and the avascular retina. Stage 2, as I told, if the line gets a height, width and a base, that is called as the ridge. Sometimes popcorn new vessels can be seen along the ridge, that is also stage 2. And extraretinal neovascularization occurs, that is the stage 3. And partial retinal detachment 4A, and if it is involving fovea, that is the 4B. So this is the fifth stage, that is the open funnel AD, where you can see the optic disc, where it is closed funnel without seeing the optic disc, that is 5A, 5B, and there is the 5C, that is this associated with anterior segment findings such as AC shallowing, neovascularization or iridocapsular adhesion. This was the terminology used by Terry as retrolendal fibroplasia in 1942. So this is the international ICROP classification 3rd edition. The first edition was in 1984, then expanded in 87 and revisited in 2005, and we have the latest ICROP 3rd edition. And now ROP is considered as a worldwide disease. Even in low and middle income countries, they had different pathologies from the standard literature. And because of the anti-VEGF was started using after 2005 and innovations in ophthalmic imaging, we needed a new classification. So the zone always remains the same. So this is the zone 1, right at the center, the circle, the radius of which is twice the distance between the center of the optic disc and the center of the macula. And zone 2 is divided as the area from the edge of the zone 1 till the nasal oris aorta, and zone 3 is the temporal crescent. So what is new in the ICROP 3? They have defined as the posterior zone 2. So the posterior zone 2 is 2 disc diopter from the edge of the zone 1. So just remember that if the disease is involving the posterior zone, it will be more worrisome than involving the anterior zone. And this is classically a notch, that is incursion of ROP lesion by 1 to 2 clock hours into a posterior zone. So earlier you would have called it a zone 1 disease, but now we know that it is called zone 1 just because of the notch. And whenever it is secondary to a notch, it will be considered as a zone 2 disease only, and it will be very much amenable to the conventional therapy. And the plus disease was first defined in 1985, but now it is considered as a spectrum or a continuum of disease which is associated with vascular dilatation and tortuosity. Whether it is arterial or venous, it doesn't matter. Abnormally looking vasculature can be considered as a plus disease at the zone 1. And aggressive posterior ROP is now called as aggressive retinopathy of prematurity, and the hallmark is the rapid development of pathologic neovascularization and severe plus. It won't go through the typical stages from stage 1 to stage 5. It will be rapid development. And more than the location of the disease, it is the tempo of the disease that is more important. It will be characterized by vascular looping, severe plus disease, and ill-defined junction between the vascular and avascular retina. So due to the time constraint, I am not going through screening, but any preterm baby of gestational age 34 weeks or less, or any baby less than that of 2000 grams should be screened at 30 days of life. And always remember the term 1, 2, 3, 4, the golden rule of 1, 2, 3, 4. The preterm babies of less than 2 kilogram and gestational age of 34 weeks or less must be screened at 1 month of age. So remember that ROP is a dynamic time-bound disease that is not present at birth. There is only a small window of opportunity for effective management of ROP. And our country tops the number of preterm birth. Rates of ROP can be considered as an indicator of overall quality of neonatal care. So remember, every single blind kid will be a tragedy. So thank you, ma'am.
Thank you, Dr. Divya. It was a really wonderful talk. So, any questions from the audience? Okay, we'll do discussion at the end. I'll call second speaker, Dr. Lekha T. She is senior retina specialist in Girdhar Hospital and taking care of ROP in Girdhar Hospital. Ma'am, to you for treatment of ROP, lasers versus anti-VEGF.
Thank you, Dr. Anubhav. Yeah. So, good morning to all of you. Before choosing what is the correct modality of treatment, let's have a little more clarity as to when and whom should we treat. And this question was answered by the cryo ROP study, which defined what is known as a threshold disease. That means any ROP in zone 1 or zone 2 with stage 3 plus disease and extending at least 5 contiguous clock hours or 8 cumulative clock hours. So at that time, only when the ROP reached the threshold ROP, it was treated, because if you don't treat, 50% of them will progress to retinal detachment. And cryo being the only option at that time, it was used to treat the entire avascular retina, extending from the ridge to the ora serrata. But when we look into the results, we can see that a significant percentage of eyes had unfavorable functional outcome. So this led to the realization that treatment has to be done even earlier than threshold or in the pre-threshold stage, and this led to the early treatment of ROP, that is ETROP study. So this study guideline says that very posterior, that is in a zone 1, any stage with plus is an indication. Also stage 3 without plus is also an indication for treatment. So we are no longer concerned about the extent in clock hours, or if the disease has come to zone 2, stage 2 or 3 with plus is an indication. And this is now we call it as a type 1 ROP. And by that time LIO was available, so the treatment was done with laser. And we can see that it helped to reduce both structural and functional unfavorable outcome, and it became established as a standard of care in ROP. So laser can be done either with the red or the green laser, and always written informed consent should be taken before any of these procedures. It should be done under proper monitoring in an ICU under local anesthesia. Start with the area which has the maximum severity and fill the entire avascular retina and try to complete the treatment in one session. Post-treatment, we give antibiotic steroids for 1 week. Follow-up is very important. Now, this is a baby with type 1 ROP, and this is a post laser. You can see the significant laser posterior to the ridge, and this is a modified concept which has come, that is known as the posterior to ridge or barrage laser, which helps to create a chorioretinal adhesion in the healthy retina and helps to prevent the progression of traction. And this is preferred in cases of advanced stage 3 or 4A where it causes faster regression. So the follow-up has to be done after laser every 2 weeks, or if you find any that the plus is persisting or there are skip areas, don't hesitate to give additional laser. And very rare cases, if there is fibrovascular proliferation and if it is progressing, then we may have to proceed with the surgical intervention. But in spite of laser, which definitely gave much more advantages compared to cryo, a significant percentage, especially in the posterior ROP, was found to have poor results, and another issue is the large peripheral visual field effect. And moreover, it is a very tedious procedure taking long time. So it is said that treating ROP needs H4, that is heads, hands, hours and a heart. So I'll just show you this picture. This is a baby who had undergone laser. You can see significant amount of peripheral retina is ablated. But if you compare this, here also the ROP lesion was in the same location. But as you can see, after the intervention, the plus has gone, the ridge has disappeared, and there is good progression of the physiological vascularization till farther into the periphery. And this is what we can now achieve with anti-VEGF therapy, because it helps to suppress the circulating VEGF levels, which is there in the phase 2 of ROP. So now anti-VEGF has become the preferred choice in all posterior, that is zone 1 or zone 2 posterior type 1 ROP in AROP, or when the laser is not feasible either due to media opacity, poor dilatation or a sick baby, and it's definitely causing faster regression than laser. So this was followed by various randomized control trials to know the safety and efficacy. We have the BEAT ROP study with bevacizumab, who found there was a significant benefit in zone 1 compared to laser, but in zone 2 both are almost the same. Similarly, the Rainbow study with ranibizumab and the Firefly study with aflibercept definitely showed that anti-VEGF has a superiority with laser, and ranibizumab is also approved by the DCGI India. So the injections are always done in the NICU, and again I'm stressing on the proper consent taken from the parents. It has to be done following all the aseptic precautions as in a case of adult injections, proper prepping and cleaning and prepping, draping. And we do the injection within 1 millimeter of the limbus using either a 1 cc syringe or a tuberculin syringe, and post-injection antibiotics has to be given for a week, and baby should be followed up within 24 to 48 hours. So one thing to keep in mind is the direction when you pass the needle. So unlike in adult cases where you direct it towards the center, here it has to be straight, parallel to the visual axis, because the lens in these babies is much thicker, and this is important to avoid any lens touch. So keep in mind the complications, because this is an invasive procedure, and the complications can also be drug related, mainly the transient effect of the injection. So by 1 month or so, the effect goes off and we have to deal with the recurrence. And we also don't know the long-term results with angiogenesis, with the development of CNS and neural retina. So all these information should be there in your informed consent and explained to the parents. So this is a case of aggressive ROP, or we can even call it as a half-zone ROP, who has responded very well to anti-VEGF injection. You can see the response is so good, and it's not like a destructive change that you see with the laser. This is another baby. We can see there is zone 1, stage 3 with plus. So as is the preferred method, anti-VEGF injection is given. And you can see there is a good improvement. The plus disease, the ridge, everything has gone. But there is a lot of peripheral retina still be vascularized. So this is what we call as regression post-injection. And as we continue the follow-up, by 5 weeks, you can see a ridge has started appearing. So this is recurrence of ROP. And for that avascular retina, we have to do laser. So now we have regression of the recurrent ROP. So this regression, recurrence are all those terms which has come more following anti-VEGF therapy. So this can occur any time between 37 to 60 weeks, and it also depends on the choice and the dose of the drug. It need not, this recurrent ROP need not go through the stages of the conventional ROP, and it always should be documented as a recurrent or a reactivated ROP. This is another scenario, again post anti-VEGF injection. You can see that the peripheral retina is remaining avascular. Even at 7 weeks or 4 to 6 weeks, the baby has reached. So you cannot continue to keep screening them, and the baby is also growing, so we have to treat them. So this situation is known as a persistent avascular retina, and if you leave it, they can develop holes and lattice. So this is another indication for laser following injection. So as we can see, anti-VEGF has its ups and downs. The main problem is a high recurrence rate and the need for a long follow-up, whereas with laser, all this is overcome, but it is a more destructive treatment. So to combine the advantages of both, we resort to the combination therapy, where the initial blocking effect of VEGF and the continued suppression by laser is being utilized. This hopefully helps to reduce the dose of the anti-VEGF and less recurrence, so that less follow-up also, and you get a much better visual field. And it has been found to be superior compared to the laser. So standard of care for ROP even now is laser, but combination therapy is an option when you are dealing with zone 1 or zone 2 posterior and in AROP. But we don't have the final answer for many of issues like late recurrence, which is the ideal drug dose, and extended follow-up has to continue for any baby following anti-VEGF. And finally, the choice depends on a case-by-case basis. And this is my teacher, Dr. Subhadra Jalali, and from sight to blindness, you can make the difference. Thank you.
Thank you, ma'am. It was really wonderful description of ROP. So I'll proceed and we'll go to next talk, ma'am. I'll request Shravnan sir to please, sir is authority in vitro retina in Arvind Hospital, Coimbatore. Sir will be talking on surgical aspect of ROP and tele-screening, how to proceed further in further promoting ROP and dealing complicated cases. Sir, to you.
Thanks, Anubhav, and thanks, Rekha madam, for having me here. So I'm just filling in for Dr. Parag, who is not able to come because of some mother's health issues. So when you are dealing with, as rightly pointed out by both Dr. Alex as well as Dr. Lekha, that when you are dealing with a premature baby, we want the pediatrician to manage the baby in such a way that we don't get any sort of retinopathy, or at the maximum milder stage 1, very mild disease. But in case they go on to treatable disease, like Dr. Lekha pointed out the guidelines of the early treatment ROP studies. So we can see that timely management with both injections and laser should be able to prevent and give a very nice outcome. You can try to limit the amount of laser and a very favorable anatomical outcome also. But there are occasions where, in spite of all these, we end up with very bad disease because of the tractional complications, or because of improper sensitization of both the NICU personnel and doctors. They end up not getting screened and then end up with such a eye. So we don't want to see this, but in case that happens, we need not lose hope and try to intervene as early as possible. And as I already pointed out by the first speaker, you can see that we have the stage 4 and stage 5. 4 meaning that if it's in macula is involved or not, depending on that we have 4A and 4B. And in stage 5 it is total retinal detachment. So before we consider surgery in these patients, we should first thing is to see whether the patient is fit enough to get operated. We have had patients who are lowest birth weight is around 650, which are operated not at the time of surgery. So we had to call the NICU in charge along with the anesthetist to be present in the theatre during the surgery, because they are very critical and they may collapse at any time. So we need to have very good backup. So other normal babies we operate and immediately shift to the NICU after the surgery. So the baby should be fit enough to undergo this surgical procedure, anesthesia procedure, and proper evaluation to get the anatomy of the disease by both indirect ophthalmoscopy and ultrasound is very critical to understand how to deal with these eyes. So a very early mild regressing disease, when there's a mild TRD, you can always observe. But for stage 4A, a little bit more in the periphery, you can do scleral buckling, which causes alteration in the fibrovascular remodeling of the fibrosis, which can lead to reattachment of the retina. But that can be seen only in a very few percentage of eyes. So usually in significant disease, we need to do some sort of intraretinal procedure that can be a vitrectomy with the conservation of lens in patients who have a stage 4 disease. And in stage 5, there's no option, but you have to deal with we have to remove the lens because there's no space between the lens and the retina. And sometimes when there's corneal complication and corneal scarring, when patients come in very late, you may have to do a combined keratoplasty and open sky vitrectomy in those patients. We had 2-3 cases which are done, but they did not do well. So that's something which you don't really want to do actually. This is one of the older videos showing the 20 gauge surgery being performed in stage 4 disease. You can see the bulky the instruments, and you have to keep in mind that the preterm babies have a very small eyeball, and using these bulky instruments was a little bit difficult, and the suturing in the thin and elastic sclerosis was not very easy. So recently we have all shifted to both 23, 25 and 27. So we usually prefer 25, and sometimes we do 27 also, depending on the instruments available in our hospital. So which makes life a little bit much more simpler, and you can get away without suturing in a significant number of people if it does not, the ports do not leak. And in stage 4B, the disease surgery is very minimalistic. We just try to remove the traction. There is no need to induce PVD. There is no need to peel off all the membranes. So we try to limit and release the traction. And in case the laser is inadequate, to do some little bit of laser and stop there. So actually, the surgical time is quite less compared to adult vitrectomy in either an RD or a diabetic retinopathy. Only thing is you should take care to avoid lens touch, and don't be too aggressive trying to peel all the membranes and ending up with breaks. Because once a break happens, that is the end of the story. There are a few cases where in spite of breaks they have survived, but otherwise a break means the surgery is over at that point of time. In stage 5, as you can see here, we have to sacrifice the lens, and usually we try to go anterior to the iris, because we don't know what are the fibrotic elements present behind the iris, which may cause, we are trying to introduce instrument that can produce a retinal dialysis at the base. So to avoid that, we try to go in anterior to the iris plane, and also try to remove all the lens elements, because remnant capsules can produce considerable postoperative fibrosis, thereby causing late failures. So first thing is to remove the lens and all the capsular elements, taking care to remove all the capsular elements, and then trying to do this two-hand technique to avoid traction on the periphery, because if you induce a little bit of traction on the periphery, it can lead to retinal dialysis in the periphery because of the significant fibrotic elements. And first is to divide the central fibrotic element into multiple quadrants, like dividing a pizza or a pie, whatever you call it, and then you try to open up the funnel. And once you are sure that you have released most of the anterior traction, then you can sometimes inject a visco. Sometimes you may have to do a subretinal drainage like you do in scleral buckling to sort of mobilize some space for doing all these procedures, but that's in a few percentage. But most of the times we can get away without drainage. But in advanced cases, or when there's altered blood in the subretinal space, you may have to do external drainage to make up for some space. You may close with the BSS or with the visco to prevent reclosure of these folds of the retina. So if you are injecting a visco, keep in mind that the glaucoma postoperative should be taken care, which is sometimes not very easy, so you have to be aware of that also. So in case we can get away without injecting visco, that is okay, but in case you need it, don't hesitate to use it. This is one of our older analysis. In 2009, we did a small analysis of what the results were in our population of babies. So we had around 33 cases, of which we had a success of around 48%. This includes both stage 4 and stage 5, as you can see here. And as you can see here, the endemic success in a stage 5 baby is not that very great, so which is something which we don't want to encounter and operate in these cases. Some photographs from that study. So you're dealing with this surgery, you have to understand all these implications of the adhesions from posterior to ridge, ridge to ridge, and anterior to lens to ridge, and as well as periphery to ridge. So unless you understand these things, you can easily cause retinal tears and end up with a failure. And the distance which you enter the eye, as already pointed by Dr. Lekha, so it depends on the age at which you operate, and this is the millimeters from the lens, the limbus which you enter to avoid both lens stretch. And because the pars plana from the baby is not that very well developed, you have to go through the pars placata, and usually it's around 1 to 2. And initially we did not have the short trocar cannulas, because when you're introducing adult cannulas, you can easily injure the opposite retina or sometimes the lens also. So now we have the short, both from Alcon as well as Aurora, we have the short cannulas. But initially what we used to do is, so you introduce a small silicone tire, 240 tire, to create some space between the tip, so that the entry of the trocar inside the ear is lesser, thereby avoiding unnecessary injury to the opposite side retina or the lens. So this we just hook onto the trocar cannulas and then use it as it is. So now we do have short cannulas, so now we have stopped doing this, but this was the initial sort of modification which are using to prevent injury. So this helps the entry of the trocars to shorten the entry of the trocars. There's again some results from that second study which we did. So this is actually one more study, a recent study for stage 5 25 gauge surgery, and you can see here in this now we had better results compared to the older study, which included both the stage 5 also. And as already pointed by the first speaker, the stage 5 you have A, B and C depending upon whether disc is seen and disc is not seen, and whether there are anti-segment complications. So there is a small study, nice study to prognosticate the outcomes of stage 5 surgery. And this is one of the studies by Dr. Mano et al. So around 54 eyes were included, and they showed that the complete reattachment was obtained in stage 5 eyes where the disc was visible, and 39%, 40% in patients who had RD with the invisible disc, and in stage 5C they were considered to be inoperable in most cases, because I told you these corneal complications may warrant keratoplasty, open sky vitrectomy. We have done only 2 cases in hospital till now, both were failures, so we have stopped doing that actually. We have to do keratoplasty along with the surgery. So one take-home message is that do not give up in these babies who end up with the serious complications, and long-term follow-up, as again Dr. Lekha pointed out, these people can end up with late, even after the 13-14 years, they can end up with the breaks and RD. We have 2 cases of early vitrectomy we did, and after 13 or 14 years of age group, they have developed peripheral tears ending up with the recurrent retinal detachment. That was initially TRD, which now went in for a reg-RD after so many years. So apart from that, you have to watch out for the refractive errors, the glaucoma part, which is very significant, which may be missed by routine people, and also the amblyopia management in these kids. And sometimes these kids may be not normal, so they may have cognitive disability, which also needs appropriate address. It has to be addressed. And in cases where they end up with very poor vision, don't just send them home. Always tie up with some facility which gives them both educational and vocational guidance, because a lot of parents are not totally lost, and you have to guide them to so that the kids do not end up as a vegetable at home. So try to help them to move on life in spite of having a poor vision. Thank you for your attention.
Thank you, sir. So you can continue with the same next talk also.
Okay. So this is regarding the ROP telescreening which you are doing in a hospital, a pet project of Dr. Parag. He's put a lot of passion and effort into this because initially we felt that we are only able to, the limited manpower which we have at Arvind, we are not able to cover a lot of NICUs, both surrounding both the multiple, we have around 4-5 districts around Coimbatore, which we are not able to cover. So, as already pointed out the first speaker, we have a considerable problem at hand. So, as I told you, that there is limited resources for, both in hospital or anywhere else. So, with the aid from the US aid, we started this ROP SOS, or retinopathy of premature eradication, Save Our Sight project with the help of US aid, United States Agency for International Development. And later on, we have some, for the second phase, we also got some support from Mr. Subrato Bagchi, who was the founder of Mindtree. So this is what our aim was, to set up a unit which can move around with the shuttle, RedCam shuttle, which is used to capture fundus images in neonates and kids, and use that as a screening tool so that we can avoid sending doctors and we can send trained personnel. So this is what this is a RedCam shuttle, which is a sort of a mobile version of the RedCam, which is a little bit less heavy and it can be easily moved around. This has got a laptop instead of a desktop. But otherwise the kit is almost same only, a little bit lesser weightage compared to the original thing. And these so-called trainers, screeners are trained by using the model eye in the initial phase, and then in the hospital under guidance we have either a senior trained person or the doctor himself. They are trained to screen on premature babies. So after the training, they are satisfactory and their competence is satisfactory. They are sent in a van to all the peripheral NICUs, and each week we have one hospital. We have around 2 vans which move around the various districts, and this van is customized to carry this RedCam shuttle. So it has got a spring spring bonds, which helps to prevent and a padded compartment for preventing the damage of the RedCam shuttle when the van bounces through uneven roads, so it prevents damage to the shuttle. It's got a padded room and a sort of elastic buckles to move it around and also not get injured. This fan facility also has the mobile unit, the Iridex laser, which can be taken in case a patient is screened to be found to be having a treatable disease. Then the doctor visits the hospital in the next strip, and they can do the laser at the NICUs in case the patient is not fit enough to be moved to the main center. So this image which was captured using the RedCam or then transferred to the base center using the cell phone GPRS and the current 4G and 5G technology. And we have doing this retinopathy screening called the Arvind diabetic retinopathy eyes screening, which we have the software for screening a diabetic retinopathy. So a modified version of this software was initially used. We have been using it for the retinopathy of prematurity screening also. So the same software which we use for DR screening. Again, we have a mobile slit lamp as well as fundus camera for DR screening. So the same what we used in that, it's called the address system. So that was modified and used for the ROP screening also. This is currently what are some of these districts which you cover from Coimbatore. So we have few districts in Kerala also, but mainly we are dealing with the Karur, Namakkal, Erode, Tirupur and Salem districts. So this is what we do. Apart from the screening process itself, we have a lot of posters in the entrance of the NICU so that the parents are also aware of what should be done for their premature babies. Apart from the general care, that eye also needs to be screened. We also the NICU staff to distribute these pamphlets so that in case they get discharged, they can come to the hospital for the follow-up of the screening. And also people who have been enrolled in this ROP SOS, we send regular SOS SMS in case they skip their follow-up visits. So totally, in this project, in the first phase, we from 2015 to 2017, around 7,000 babies were screened, of which 111 babies had found to be severe ROPs, and laser was done to 129, and 84 patients got injection, and 4 eyes ended up with a significant disease which needed surgical intervention. Just showing a video of how this is being done. As you can see here, this is the RedCam shuttle, which is being loaded onto the so-called padded compartment with the spring bonds or what you have here, and then this is along with the van, driver, one more external staff for the helping the driver, and also two trained people go there. Around 4 people travel in the van, and once they capture image, this is sent either to the base unit where you have a desktop, but in case the surgeon is not available in the hospital, this can be accessed from a cell phone also. The software is installed in some of the we have 3 doctors who have their software installed in their cell phone also, in case they are out for some reason, for lunch or even for other reasons. So our turnover time is within the first 45 minutes, the result has to be delivered to the hospital. So we have that as a sort of an endpoint, and so in case the patient is not available, the doctor is not available in the base hospital, he can always use the cell phone to use the same software and identify and give the advice so that whether they need to be treated or observed or come back to the base hospital for the follow-up. So all this advice is given within 30-45 minutes at the maximum for 1 hour. So there was also some publication of where we saw other diseases apart from ROP, which includes routine birth hemorrhages, colobomas, optic disc anomalies, lipoma retinalis, CHERP. So all these multiple other disorders were identified during the ROP screening, which was we published that results also. Sometimes this may help to pick up other diseases apart from this thing. So apart from this, we tried to sort of educate the paramedical personnel, and we have conducted so many CME programs which showed a good impact on the follow-up of the number of patients who were able to enroll into the ROP SOS program. So again, I was discussing with Dr. Lekha also. In one of the NICUs, we had 2 major NICUs in Coimbatore, and one of the NICUs, we had a very significant operable ROP coming from one of the NICUs. So what we did was, we tried to assess what is happening wrong in this, and we realized that there was a lot of variation in the oxygen saturation of the babies because of this funnel-shaped instrument which they were using it, and whenever the baby moves, it will just come off, and there was a very less care because of the extensive crowd which is one hospital NICU had a little bit of less crowd, so they're taking much more care, whereas other hospital was almost like a government hospital, so much load going and coming out, they were not able to retain babies. Even a little bit of stability, they'll send home, then the patient will come back again with the respiratory distress. So the oxygen saturation was moving up and down in these babies, and that was the reason why they developed a significant ROP. And when we tried to educate the pediatrician, and the pediatrician understood what was happening, and so they were able to shift all their practices, and now we see very less treatable ROPs coming from that center also. So that is one of the major impacts which happened during this screening protocol. We were able to identify some of the issues with in the NICU management of preterm babies. So we also have been able to expand our screening area till Krishnagiri now. So that's what we have been doing. And now we have had a second van apart from the first Jeep. So first van, now we have a smaller version Jeep from the Mindtree support. And so we've been doing this, and now recently we've been started to use AI. So our DR screening program now, because initially we had doctors sitting and reading the images and giving advice, but now we had with the tie-up with the Google we had for the DR, we had a tie-up with Google, and now almost 99% of the images are being read by the AI, and no doctor does the reading. And similarly, we have been doing this AI reading, and now it's currently we started now. Till now, the validation was going on with the iTelligent, this Dr. Paul, Dr. Peter Campbell, and Dr. Michael Chang. So IROP, there was a project, and they did this both in the West as well as in India. So they have had considerable specificity and sensitivity in this AA, and now we are trying to implement in our hospital also. So now the load on the doctor, because they have to take care of the routine OPD work, surgical work, as well as the screening works. Now we are a little bit more happy that our workload is less. So this AI now we are just setting in. So hopefully this will decrease our workload in the coming years to come. So we are also had a small comparison with the RedCam as well as the low-cost handheld cell phone-based systems. Unfortunately, these handheld simpler devices were not able to give that very nice photographs like the RedCam could, and there was a very intense, like what you call a skill intense procedure. So even if the screener is not that very skillful, they could not get clear images, especially of the periphery. So right now, the truth is that the cell phone based cameras are not a very reliable tool for, especially for ROP screening. So it's better to use the established capture systems like the RedCam or the 4S. As I told you, the cell phone, this is the limitation. So as I told you now, with all this, we have been able to take care of a larger population which was not able to do when you are doing a physical doctor screening. So with the help of the paramedical staff, we have trained them, and now the area and the number of children we are able to cover is very vast, and this has helped to reach out to much more peripheral NICUs. And this has made a really big impact in our care delivery to the preterm babies. I'll stop here. Thank you for the attention.
Thank you, sir. Thanks for this really enlightening talk on telescreening. We actually need this, and this can change the whole ROP game all over India. And the AI is giving significantly good results. It's a good thing.
And we should not have a hesitation to accept the advances in technology. I think first thing is we should overcome our mental block, and we have somebody to share his experience so well. So that was very useful. Thank you so much. And a special thanks for accepting it in the last minute and covering it for Dr. Parag. Thank you so much. So now I invite my colleague, Dr. Anubhav Goyal, and he's also giving us a very practical talk. Anubhav has an important role in expanding the ROP work at Giridhar Eye Institute. So he's going to share his experiences to encourage youngsters to take up ROP work and to know how to overcome the various roadblocks you have. Over to you, Anubhav.
Thank you, ma'am. Thank you for giving this talk. So I'll be talking upon setting up ROP program. So as Dr. Divya has already told, ROP and Sir has already told, ROP blindness is a premature birth are huge in numbers in all over world, and India is the kingdom of all the ROP premature births. And if you see this 1 out of 10 babies who are having premature ROP is actually 18,000 who needs treatment out of 3.5 million premature births. 18,000 is a big number. We have to deal with such a big number. We need more and more understanding and proceeding. So I'll just cover a few important things. We all should understand the golden rule of ROP for screening. 1, 2, 3, 4. One is premature baby should be screened within 1 month of birth. All babies less than 2,000 gram should be screened, and all babies less than 34 weeks of gestation should be screened. Babies who are extreme premature less than 28 weeks should be screened a little bit earlier, like 2 weeks of birth. But otherwise, usually what Dr. Divya told, our ROP present usually 3 to 4 weeks after birth only. We can delay the screening till 1 month. So screening should be done preferably under good monitoring, preferably in ICU, but you can do in ROP, in your OPD also, when the baby is stable and discharged. But if the baby is still in the ICU, you should make sure you should go to an ICU, and in the hands of trained person only under monitoring, you should screen the baby. For screening, the ROP drops has to be made. There are a lot of companies which are providing ROP drops. But then the standard drops what we are getting for adults, we can use them and dilute it with 50%, and you can use these same drops for dilating the ROP babies. These have similar concentration of tropicamide and phenylephrine, which is recommended for ROP drops. So the important thing is teach NICU staff how to instill these drops, because extra putting drops, keeping this drop contact for skin for long time can cause systemic absorption and can cause fatal systemic complication like bradycardia and apnea. So immediately after putting the drop, you have to clean the skin and eyelids so that it should not cause any systemic complication. And for screening, eye should be properly dilated. Improper dilatation, small pupil, what we do in adults like pinpoint imaging should not be done. ROP is a problem which its dilatation itself is important, give you a very good clue that it's not a severe urgent ROP. If dilatation is not there, you have to be cautious. It can have iris new vessels, NVI, and an advanced stage AROP type of picture. So dilatation should be taken care of very nicely. So examination, as I told, should be done in an ICU, and treatment is also should be done in an ICU. You can actually screen babies through the incubator also. So if babies should be taken care of, baby should be taken as priority. Should be screening should be done as per the baby's comfort, not as per your comfort, and all the parameters should be taken care of very nicely. Always monitor and resuscitate baby during screening and treatment. Babies can have apnea and all during the screening part also. So the contact person in an ICU is the most important person which will coordinate with you for screening and treatment. That person is preferably a neonatologist from the team of neonatologists and a nursing staff. So that one person or a coordinator of that ICU that you have to keep under your constant coordination, and that person will call you for periodic screening, periodic dates, and coordinate with patients. So that person you have to identify and mark and keep that in constant loop. So key point is identify the ICUs which have huge number of premature births, keep constant touch and coordinate with them for a good ROP screening. MOU has to be signed with all these hospitals, because if you don't sign ROP, they might call you, they might not call you, and they might call someone else. But the problem is, if they are not calling regularly, premature screening ROP screening can be delayed and can cause further worsening of ROP. So MOU has to be signed so that periodic screening can be done. Identify the pediatrician in charge and keep them in loop. What is happening with the ROP, what baby they need to be screened or baby need to be treatment, what is the stage, everything you keep, you explain everything on the your consecutive visits, so that they should get an idea that what is happening is according to and how they can manage the ROP and presentation on all the babies. So identify a staff nurse or coordinator which you have to keep in the loop. And most important thing is, fees is the most important thing which can shut down your screening. This is the most important part which I have personally feel in my journey in ROP, that fees matters a lot. If you charge a lot, initially you can pick up, but then slowly the screening might come down. So fees or the money what you are charging for the other screening or treatment should be comfortable to the team and to the patient both. So keep a fixed day every week. You can shift 1 or 2 days earlier or later, but fixed day every week should be there for particular hospitals so that they can coordinate with the baby, because baby might be needing ENT follow-up, pediatric follow-up also. So they can combine ROP screening with that, and it will be easy for them also, because priority is a comfort of pediatrician and the baby, and you have to do ROP screening with their comfort also. So keep register of ICU with you not to miss any finding and to give you detailed advice, and you have to keep the data of baby with each and every finding. Baby identification card is a very important thing which gives an idea of how the ROP is progressing to the pediatrician and to you also, and which will help parents to keep the finding and for their future follow-ups with the other doctors in later life. So this is a ROP documentation form which you can give to the pediatricians and can keep in the file so that they can you can record your findings. This ROP card you can see on the left side, you can keep all the details in your hand, and right side you can write all the details, what is the follow-up, which date you screen, and slowly you can check how the baby is going on in terms of ROP. So baby is not born with disease, but with your efforts, this disease can be taken care of very nicely. And since it has a lot of medical legal implications, a lot of people are fear or not to do it. But now, with the more awareness and understanding that if you screen timely, if you treat timely, this is not a medical legal issue anymore. You can take care of babies. We need more manpower to take care of ROP. We need more instrumentation to take care of ROP, because number is still huge and we have to do more. So there are a lot of medical legal cases against ROP. Mostly in most of the cases, pediatrician is being blamed, but yes, we are also a part of that blame. So we have to take care of it very, very cautiously, but very strongly. And counseling parents, informing an ICU staff, everything has to be done very nicely on every visit, and you have to keep the details and you have to be transparent to the parents, make the parents understand what is happening. So here comes you can use these posters which give you information of screening, and here comes the importance of imaging, what sir has already told. This is an image which I usually prefer to keep in my mobile to show to the parents how the stages are seen. So either a ready image you can keep so that parents can understand what is stage is going on, which is what stage, and what stage need treatment, and what are you seeing there if you don't have imaging thing in your hand. So moral and legal responsibility of getting the baby to the ophthalmologist is basically by pediatrician, keep him in loop. Trained ophthalmologist is important, or a trained optometrist with a red cam can be a good your assistant who is available constantly. You should not change the ophthalmologist. You should not changing ophthalmologist, changing assistant is not a good thing for screening. As I told, fixed day is important, and even single critical and admitted premature baby is important and should not be missed for screening. For each baby. Check if the baby you have basically for each baby you have to check the systemic parameters also, why if the ROP is not maintained, and oxygen saturation, other body parameters, because anemia is the most significant risk factor. What we have seen with the worsening of anemia, you can see worsening of ROP also. Oxygen concentration also is a secondary risk factor, but is also important risk factor. So these are multiple imaging modalities which already sir has told. You can use both. A smartphone is a good device which you can take it for periphery when you don't have anything. At least some documentation is important, though it is not legally accepted, but it is an important device which you can use when you don't have anything to explain to the patients. At least something should be, you need to prove what is you are seeing to the pediatrician and to the parents. So these kind of images you can get from smartphone also, though it is not good, but then for rare cases it can be used. ROP card should be kept for at discharge to counsel parents, and this is the most important thing. I used to screen one hospital where doctor used to say, Anubhav, just see red reflex and tell what baby is okay or not, because this is a priority hospital, VIP hospital, we cannot take risks with the babies. So I told him, sir, I will not do anything without dilating the baby. I have to screen the baby with dilatation only. So red reflex is a fallacy. You can have advanced stages with red reflex and severe ROP with red reflex. By the time you dilate, baby will come with a white reflex. So don't screen baby just for red reflex, dilate properly and screen retina. ROP has severe lifelong implications with lifelong blindness. So termination ROP should be done after retina is fully vascularized, without treatment or with treatment. We have many unsung, silent and happy stories if ROP is taken, and ROP is taken as enjoyment, and it should not be taken as a burden. This is a case example of a girl child who is doing very good in her class with 6/9 vision, and you can see the amount of laser scars. So there are medical legal implications of ROP related blindness. Early screening and timely treatment plays an important role in ROP prevention. Thank you.
Thank you, Anubhav, for sharing your experiences and giving many practical tips about ROP practice. Now I invite Dr. Divya Balakrishnan.
Thank you, ma'am.
She's a senior vitreoretinal surgeon and specializing in pediatric retinal surgeries. She is going to tell us about the non-ROP retinal problems which we encounter quite frequently during our ROP screening.
So, thank you, Dr. Lekha, because for want of time, I will just briefly touch upon the various illness. So first is most commonly come across few diseases. So one is Coats disease. Usually if you see it in a neonate, you may get confused it with the retinoblastoma because that presents in an advanced stage. But if you're little older, you might see these kind of telangiectasia, and if you see hard exudates, think in terms of this disease. They can have these macular changes because of the subfoveal hard exudates, but the classical picture is the telangiectasia which you see. If you have any doubt, especially in little adult children, then you should do an FFSC to see these areas of bulb-like dilatation and capillary non-perfusion. You have to keep in mind that the disease had present in various stages, so you should be aware of these diseases. And then, as I mentioned, angiography is one of the most important tools. So this is how if the disease present in very young age, then it might be in an advanced. So you have to differentiate it from retinoblastoma, which is a very mimicker. And then the treatment depends upon the stage when you present, and in advanced stage the treatment might just to preserve the globe and to prevent the complications. In the treatable stages like in stage 2A, 3, then you can do laser, cryo, anti-VEGF depending upon what is the macular involvement and extent of the disease. But one thing, when you diagnose Coats disease, you have to counsel the parents and keep in mind it is a progressive disease and you may have to take the baby for multiple sessions of treatment to achieve a disease stability. Another condition is familial exudative vitreoretinopathy or otherwise FEVR. This is a very common mimicker of ROP. Suppose you see the ROP like changes in a newborn. Like ROP usually develop at second or third week after birth. If you see it immediately after birth, then think in terms of FEVR. And one thing is that it can be a bilateral disease and the presentation can be asymmetric. So the key features are like a peripheral avascular retina, like how you see in ROP. In advanced diseases, it can present with traction, and these exudates, presence of exudates, you may think in terms of FEVR and not ROP. And again, you have to identify the various stages in which this disease can present. You have to keep in mind. And if you have any doubt, especially you have seen the FA of Coats disease, FEVR, you will see that there is straightening of vessels and abrupt ending of vessel with the peripheral capillary non-perfusion. Again, the treatment will depend upon the stage of the disease. You can observe if it is in early stage 1 or in an advanced disease where nothing can be done. And again, like almost similar to ROP, you have the options of laser, anti-VEGF, and this is one kid who was advised laser treatment when her both eyes were in this light of right eye. She did not take the treatment, turned up 4 years later. This is the status of the left eye where it has gone for occlusio pupillae. So the maximum we could do was like to do a cryo and give anti-VEGF, and this is how what you could obtain. The other eye we did a laser in that eye, so that could be stabilized. So you have to keep in mind, and surgery helps to actually stabilize the vision even in advanced stages. So if you see that the patient has lost one eye and present later with some problem and the patient doesn't have a history of trauma, thinking usually of two diseases, one is could be FEVR, other could be ARN. So that is what we usually teach. And sometimes you may get confused with the high myopia because sometimes these avascular retina can have lattice degeneration. So you just treat the lattices and then leave the other areas. So in case if any doubt of this peripheral straightening, get an FFA done, that will help you to pick up FEVR. Again, one more thing is that when you diagnose FEVR, you have to keep in mind, again it is a progressive disease. The disease course can turn immediately, and then FEVR is a lifelong disease. One more thing is that you have to do a family screening of all the siblings, and you have to look at the parents also. And in some cases, you may plan for an early delivery in these babies also. And another close mimicker of FEVR is incontinentia pigmenti. The fundus features is almost similar to that of FEVR and maybe of ROP, but you have to unwrap the baby and look at the skin to pick up this. So these are the skin changes which you see. It's uncommon, but still you come across this, and it has got some other systemic like dental hypoplasia and alopecia. Then another picture which you see is like a leukocoria. Then it could be a persistent fetal vasculature. It could be mostly unilateral presentation, and depending upon the involvement, whether it is anterior, posterior or combined, you might get different presentations. So anterior, usually you will say white dot or mostly like a microphthalmic eye. When it goes to the posterior, you might see a stalk posterior, and you have to identify when you plan for a cataract surgery the anterior attachment of the stalk. So if it is in the center, you can go from the anterior route and do a PPC kind of a thing and then leave it. But if it is in the periphery and if you start pulling, it might cause iatrogenic retinal breaks. And again, you can observe depending upon the stage when the baby present and the usefulness of the intervention or to prevent the complications. So either it is to stabilize and or to prevent the complications. So here you can see in the first video, it is in the attachment is in the periphery. So this is in the past plan, and the other you can see it is a central stalk which is lifted up. So what is the point in operating in these cases? It is basically to stabilize. So this is that patient which I showed the second video. You can see that it took 2 years for that traction to settle down. So this helps to stabilize the vision. And another condition which you might see is the X-linked juvenile retinoschisis, where sometimes, especially if the baby presents in the neonatal period, you might see that the retina is sitting just behind the lens. That is because of the huge inner sciatic cavity which comes almost near the lens. So don't get it confused with the RD or retinoblastoma. And if child is little adult, the patient might come to you with a vitreous hemorrhage, sudden onset of decrease in vision, or sometimes the inner sciatic cavity will look something like this, which sometimes they diagnose it as a giant retinal tear. So always look at the fovea, you will see these bicycle kind of a pattern or RP changes. A good investigation tool, if you can get, is an OCT or an electrophysiology. So then these are some, again Dr. Sharvana has shown in his presentation also, like some other diseases which you pick up during the screening is endophthalmitis, especially fungal endophthalmitis will not have a very fulminant picture. It will look like some small yellow dots, and some other viral retinitis, CMV retinitis, all these you have to know about these entities so that you can pick it up and diagnose. The most important thing is to diagnose it so that some has an implication for a long-term follow-up or a family screening. So it is important to differentiate. Thank you.
Thank you, ma'am. Thank you for this talk. Any questions from the audience? So, sir, 1 minute, sir.
One thing I was pointing out, like as Anubhav was pointing out the money part, a lot of times when you charge money, the NICU staff or the pediatrician, they feel that we are in this for some profit. So in our hospital for the first almost 15 years, we are doing without charging any money about whether the NICU or the patient. So and also in the ROP SOS trial, because they were getting external funding, we were charging zero for all the, except for the injections, lasers and surgery. It was totally, the screening part itself was totally free. So this we mainly need to do to convince the pediatrician that we are not in this for money. We are mainly for taking care of the premature babies. So this is one thing which because we had a lot of, because in Coimbatore we are doing this, and from other centers in Madurai, main center, Parent Institute, they were telling that we cannot do this. It will give a wrong idea to other things. So, but we were still holding because we wanted to increase the NICUs, which were we wanted to rope in more NICUs. Once you start getting money, then these people are a little bit wary and they are not willing to join us. That time, I'm talking about almost 20 years back. So for the first 15 years, we are totally doing it free of cost. So that is one thing we have to keep in mind. Sometimes you have to get external funding to make this happen actually.
Very good point taken, sir. And second thing is, for taking care of this finances, you can have a second option. Says nothing works free of cost. Institutes like Arvind can do, but then a normal practitioner, if they have to do without funding, then no one will go. So you can do. The only thing is, but there's one way out. You can take money similar to their consultation charges, so they will not be overburdened. But you have to compile babies. You have to take 2 or 3 babies so that you also should not be burdened. That is a very good way to carry on with the finances, with the pediatrician and with yourself. Thank you, sir. I request Byalamni ma'am. She is a senior ophthalmologist of our Kerala state. Ma'am, please come in front to give memento to Shavnan sir. We really say heartily thanking sir to take this call. Thank you.
So thank you for all who came to attend this IC, and I thank all my co-speakers for their contribution. Thank you very much.